Good morning, everyone. First and foremost, I'd like to welcome all of you to this postgraduate course entitled Emergency Radiology Course for Radiologic Technologists, Indications, Techniques, and Common Imaging Findings. Although the title seems to center on radiologic technologists, I'm sure this will be a very useful postgraduate course, not just for them, but all of the radiologic practitioners not in Metro Manila, and because it's hybrid even across the country. I'd like to talk about two things with radiology and where it is now in the country, maybe in the world. Number one, as far as radiologic technologists are concerned, we are experiencing, as we have in the past, a dearth or a lack of radiologic technologists for multiple reasons. We train a lot of them, but many of them are, of course, attracted to better employment opportunities abroad. Not just attracted, even pirated by other institutions. And it's a phenomenon that we've seen both for nurses, allied medical professionals, and radiologic. RadTech is not an exception. Having realized this, St. Luke's does not stand in the way of this. We know that people will always seek for better employment opportunities, better lifestyle. So what have we instituted? Well, what we have instituted really is to increase the number of RadTechs that we are training, increase the number of RadTechs that we are accepting, to create a buffer of radiologic technologists, because I think in the end it addresses not just the needs of St. Luke's but the needs of the country in general. Training more people in this area where skill is very crucial and where the demand is very high is a worthwhile endeavor, not just for our hospital but for the entire country as well. And I think this postgraduate course redounds to that objective and delivers that objective of increasing our population of capable, skilled, and even expert radiologic technologists. The other part of this postgraduate course that I'd like to address is also the continuing medical education of our radiologists, even our radiology residents and fellows, and I think this is very, very useful for everyone. There was a point very recently that has always been coming up in medical circles about the advent of artificial intelligence in medicine. And slowly but surely, artificial intelligence is creeping up on everything that we do. I am sure that many radiologists have been given a scare or given a warning that at some point AI may replace all of our diagnostic or imaging interpretations. While there may be some semblance of concern about that, I think, especially as far as St. Luke's is concerned, we are still relying very heavily and this is going to be true in the future, that the machine cannot replace the expert or the doctor. The machine cannot get the clinical insight that the doctor has. And the machine, for all its the machine, for all its capabilities and for all its wonder and for the potency of its computing power, I think will never come close to the practice of the art of medicine. Hence, I don't see a future wherein radiologists become a dinosaur or a thing of the past. In fact, I think with the advent of AI, we can harness AI and leverage on AI to increase accuracy in radiologic imaging that is complemented both by AI and also by the doctor. And I think that the art of medicine can still be preserved, and that is where we are in the culture of care in St. Luke's. I don't think that there will ever be a time that we will relinquish anything fully to just AI. We will always need doctors, we will always need experts, we will always need practitioners, because at the end of the day, it's the care of the patient that matters most. So with that, I'd like to congratulate your chairman, Dr. Maricar P. Reyes, the organizing committee of this postgraduate course.
Good morning to everyone joining us today. On behalf of the Institute of Radiology of St. Luke's Medical Center, Global City, it is my great pleasure and honor to welcome you all to this postgraduate course entitled Emergency Radiology Course for Radiologic Technologists, Indications, Techniques, and Common Imaging Findings. This webinar is part of our continuing commitment to support and empower our partners in radiologic imaging, especially our radiologic technologists, who play an indispensable role in every imaging department. Whether you are a practicing professional, a student preparing for licensure, or a radiology resident looking to deepen your emergency imaging knowledge, this course is for you. Radiology is and has always been a team effort. The clear, high-quality images we interpret as radiologists start with the skill and dedication of our technologists. Without them, there is no radiology department. You are vital to both the process and the outcomes of patient care. We are proud to have with us 5 esteemed speakers, all trained through the fellowship programs of St. Luke's Global City. They now practice in key centers across Luzon, Visayas, and Mindanao, a testament to the reach and impact of our training and the collaborative spirit that unites the radiology community nationwide. We also sincerely thank our industry partners who have consistently supported the academic and clinical endeavors of the Institute of Radiology. Your partnership makes programs like this possible and allows us to continue promoting excellence in radiologic education and practice. Let today be a meaningful exchange of knowledge and experience grounded in our shared mission of delivering high-quality, patient-centered care. Once again, thank you for being with us this morning and welcome to our course.
Pleasant day to each and everyone. It's both a privilege and an honor for me to be part of this momentous event. First, I would like to express my appreciation to the organizer, St. Luke's Medical Center, Global City, Institute of Radiology, for sponsoring a scientific program like this for the benefit of the RadTech profession in the Philippines. Maraming salamat po. On behalf of the Philippine Association of Deans and Faculty of the College of RadTech Incorporated, I would like to thank the organizer, Program Director, Dr. Bernard Laya, and also the overall chairman, Dr. Maricar Reyes. Maraming salamat po, and we're looking forward to have a partnership, harmonious relationship with the organizer. Hopefully po magkaroon tayo ng series of seminar to cater the needs of RadTech in the entire Philippines. Looking forward, ma'am and sir, and hope you enjoy the program. Congratulations po, and God bless us all.
Our first speaker this morning to talk about acute neurologic emergencies is Dr. Leah Teresa Torres-Cortez, a neuroradiologist from St. Louis University Hospital, Baguio City.
So good day to everyone. I'm Dr. Leah Torres Cortez, and I'll be discussing about neuroradiology emergencies with the following outlines: introduction to neuroradiology, imaging modalities, and recognizing neuroradiology emergencies, aiming to answer the following questions: what, when, where, why, and how. So to begin the discussion on the introduction to neuroradiology, we will answer the question what. So what is neuroradiology? Neuroradiology is essential for initial evaluation of patients with a clinical suspicion of brain and spine disorders. It is required to obtain a probable diagnosis to support treatment decisions. Neuroradiology has undergone tremendous development during the last 40 years. There's now the advent of functional MRI, tractography, or PET scans to aid in diagnosis. But ultimately, the mainstay of neuroradiology, especially in emergencies, will always be CT scan and MRI. Conventional radiography of the skull and spine provides very limited information and is rarely used in neuroradiology. Moving on to recognizing neuroradiology emergencies, I have divided them into two categories: non-traumatic and traumatic. For non-traumatic, the most common neurologic emergencies include acute ischemic stroke, acute hemorrhagic stroke, and subarachnoid hemorrhage. For trauma, we will differentiate epidural versus subdural hemorrhage, subarachnoid hemorrhage, and diffuse axonal injury. So discussing first on stroke, we will be able to answer when and where. When is the right time to obtain imaging and where? So upon rapid identification of stroke, immediate EMS transport to the nearest stroke center is recommended. That is to answer the question where. And the right time to imaging is always before any form of treatment be given. And then we begin to answer the question why. This is to most of the time determine the safety of giving your standard medications like IV fibrinolysis. Remember, these are clot busters, which are contraindicated for those with intracranial hemorrhage instead. So why do we have to do it as quickly as possible? Why do we have to pull out the ongoing MRI scan to cater to this stroke patient? Remember, time is brain, brain is time. 1.9 million of neurons are lost per minute passed, and so it is recommended that the mean to door imaging time of 20 minutes should be achieved in different hospital settings to save as many neurons as possible. Non-contrast enhanced CT is already effective to exclude ICH or intracranial hemorrhage before IV alteplase administration. I think we are all familiar with how a hemorrhage looks like on CT. It is an area of hyperdensity with the Hounsfield unit of 65 to 95, compared to the bone, which is highly dense at 1000 HU, and air, which is highly hypodense at negative 1000 HU. If patient manifests with stroke and we do not find this hemorrhage, then we can look for early infarct signs. Early infarct signs include a hyperdense vessel sign, which is the direct visualization of thromboembolic material within the lumen. Under its umbrella term is your hyperdense MCA sign, your MCA dot sign, and hyperdense basilar tip sign. So this is an example of your hyperdense MCA or middle cerebral artery. So we see it more hyperdense compared to the contralateral right. This is an example of your MCA dot sign. So this is located in the M2 segment of the middle cerebral artery rather than the M1 segment of the middle cerebral artery. Now this is an example of a hyperdense basilar tip sign. This is also a true neurologic emergency. Remember that your basilar artery is supplying your brainstem, and your brainstem regulates vital functions like breathing, consciousness, heart rate, and blood pressure. We also have your insular ribbon sign. Remember that an infarct is a cytotoxic edema. So its density is nearer to that of water, which is dark, like that of CSF, as opposed to the hyperdense acute hemorrhage. You also have the obscuration of your lentiform nucleus. So here we see an area of hypodensity compared to the left. So if you think something is suspicious, then don't hesitate to provide us radiologists with a recon of the ischemic window, which will help in easier detection of infarct. So this is an example of the stroke window. Again, another of your ischemic window with the infarct in the right temporal lobe better seen compared to your brain window. Early infarct sign also include the loss of gray-white matter interface, which will include effacement of the sulci and adjacent structures, and of course hypoattenuation compared to the contralateral left. So when does MRI become extremely useful? Although CT scan is adequate in most treatment decisions, some institutions actually have MRI in their brain attack protocol rather than a CT. First, because your MRI bath is tailored to 10 minutes scanning time rather than the usual 20 minutes routine MRI scan. So it is still within the recommended door to interpretations time of 45 minutes. And also because it has sequences which can detect ischemia within minutes, so that's DWI, can detect ischemia within 4.5 to 6 hours of onset, which will be for flare, and can also rule out hemorrhage for alteplase safety through the GRE sequence. So again, MRI can be useful to those patients with wake-up strokes or have unclear time of onset 4.5 hours from your last well-known or at baseline rate. Because it is suggested that if you have a DWI flare mismatch, then time of onset is usually within 4.5 hours. So this is an example of a DWI flare mismatch. So you see an area of hyperintensity on DWI, but with no corresponding hyperintensity on flare, a suggestion that the stroke is within 4.5 of onset and can therefore be given your alteplase. This is as compared to your match. So DWI flare match, which is a hyperintensity on both DWI and flare, meaning the patient is already contraindicated for IV alteplase. So this is just to show you how a hemorrhage looks like on MRI. So it's an area of hypointensity on GRE sequence. The other sequences are T1 and T2, which will help us age the hemorrhage. This is also why we added T1 to the usual stroke protocol, where T1 is usually not included. So DWI has emerged as the most sensitive and specific technique for acute infarct because it can detect small cortical, deep, and subcortical lesions called lacunar infarcts, and it can detect brainstem and cerebellum infarcts, which are obscured by beam hardening artifacts in your non-conscious enhanced CT scan. This example is just to show you the difference between CT and MRI. So here it is very difficult to see the area of infarct in the right frontal lobe. Compared to the MRI, DWI, where it is readily seen. This is also an example of MRI performing better than CT scan in the posterior circulation. This tiny hyperintensity here can definitely not be seen on CT scan because of beam hardening artifacts, but MRI will provide you with better information. Sometimes your radiologists might also request for additional coronal slices. You think this may just lengthen the time of acquisition, but understand that of course it is for better visualization. Okay, so now moving on to another neurologic emergency, subarachnoid hemorrhage. Subarachnoid hemorrhage, where the most common presentation would be headache. Well, of course, there are many other causes of headache, but one of the most dangerous ones would be subarachnoid hemorrhage. And this is why you scan so many patients with headache and why we read them. Non-contrast CT is the main modality, and because a ruptured intracranial aneurysm could be the cause, the patient could be for possible surgical clipping or endovascular coiling, and therefore its dissection is necessary to a follow-up CT angiogram. So expect a CT angiography request when you see a subarachnoid hemorrhage. As you can see here, the hemorrhage is not in the parenchyma, but it is rather in the suprasellar cisterns or in the sulci. Now moving on to trauma cases of emergency neuroradiology. So non-enhanced CT is critical for triage, but MRI has higher sensitivity, especially in cases of diffuse axonal injury. The most common hemorrhage in trauma is also subarachnoid hemorrhage, traumatic subarachnoid hemorrhage. This is different from subarachnoid hemorrhage from ruptured aneurysm. So traumatic subarachnoid hemorrhage is usually found in the convexities. This is as compared to a subarachnoid hemorrhage from a ruptured aneurysm, which is usually found in the suprasellar cisterns along the circle of Willis. So these are the most common sites of aneurysms, which are found in the circle of Willis. And this is why blood pools in the suprasellar cisterns instead of the convexities. Now we differentiate a subdural hematoma from an epidural hematoma. Here you can see that a subdural hematoma is concave or crescent shaped because there's trauma to the bridging veins, and it is seen like a banana. While an epidural hematoma is convex or lens shaped because there's trauma to the middle meningeal artery, and it is seen like a lemon. One of the clues also to differentiating subdural hematoma from epidural hematoma is that subdural hematoma crosses suture lines compared to epidural hematoma that does not cross suture lines. So this is an example of a subdural hematoma crossing occipito-parietal suture, and an example of an epidural hematoma that did not cross the lambdoid suture. Moving on to diffuse axonal injury. So this is a severe form of traumatic injury, difficult to diagnose on CT because findings can be subtle, as in this case. This hypodensity here can be easily missed. So MRI is usually requested if CT findings does not reflect clinical signs and symptoms. Diffuse axonal injuries can be hemorrhagic or non-hemorrhagic. In this case, it is non-hemorrhagic. So this is comparing it to an MRI which has clearly defined diffuse axonal injury along the corpus callosum. So it is seen as an area of hyperintensity on flare sequence. This is another case of diffuse axonal injury where CT scan was only able to detect hemorrhages in the right frontal lobe and genu of the corpus callosum, whereas your MRI SWI sequence, SWI sequence, shows much more extensive hemorrhagic lesions in the same region of the right frontal lobe and also involving the genu of the corpus callosum. There are also hemorrhagic lesions in the left basal ganglia and fornix that are not seen on your non-conscious enhanced CT.
So that is towards my last slide. And finally, I would like to conclude by answering the question how. So how will we be able to work for the better of our patients? I think we all know the answer to that, and this is through the collaboration of doctors and radiation technologists with well-equipped knowledge about their imaging modalities, their indications, and essential findings. So thank you for listening.
Thank you very much, Dr. Torres Cortez, for an excellent and very important talk on neurologic emergencies. Our next speaker is Dr. Kais Pumani, a thoracic radiologist from St. Luke's Medical Center Global City Institute of Radiology. His topic is on acute, thoracic, and cardiovascular emergencies.
Hi everyone, thank you for joining us today. This session is all about helping RadTechs to spot the signs that really matter in emergency chest cases. I am Dr. Kais Momani from St. Luke's Medical Center Global City, and let us walk through some practical tips, key findings, and common pitfalls in thoracic imaging. Before we dive into the discussion, I'd like to start with this simple but powerful quote. Behind every clear diagnosis is a clear image, and behind every clear image is a radiologic technologist. I just want to emphasize that your role as a RadTech is very important. A radiologist can only diagnose what they can see, and they can only see what you capture well. So this session is more about the impact of your skills on patient care, especially in emergencies. For our learning objectives, we will review the thoracic anatomy relevant to imaging interpretation and acquisition. Next, we'll go over the common clinical indications for thoracic imaging in emergency settings. Then, we'll review important thoracic emergencies and what those conditions typically look like on imaging. And we'll also focus on critical findings and cover some practical tips for image acquisition and pitfall recognition. Let's start by revisiting some basic anatomy as seen on X-ray. This foundation is especially important in emergency settings where even subtle changes can point to serious life-threatening conditions. On the right, you'll see a helpful 3D overlay showing the major cardiovascular structures, including the aorta, pulmonary arteries, atria, and ventricles. This kind of visual helps us better understand how the heart and vessels are positioned in relation to the lungs, and more importantly, how their abnormalities might appear on a standard 2D chest X-ray. Looking at this lateral radiograph, on the right side, the diagram shows us how the heart and blood vessels sit in the chest. The big red arch is the aorta, which carries blood out of the heart. Adjacent to this is the pulmonary artery. The left atrium is at the back of the heart, the right ventricle is at the front, and the left ventricle is at the bottom and back, and the blue tube below is the inferior vena cava. And just a quick rundown of the key structures labeled on the right side in this axial contrast enhanced CT of the chest. As we scroll down, we see the key structures and their relationships with each other, which is anterior, posterior, and what structures are on the right and left side. It is important to be familiar with the normal anatomy of the mediastinal structures, as this may be different in some patients, especially those with congenital defects. So when do we do emergency chest imaging? Let's start with difficulty of breathing. This is one of the most common reasons for imaging. We are looking out for things like pneumothorax, pulmonary embolism, asthma, or COPD. Then there's chest pain, especially if we suspect something cardiac. In trauma cases, imaging helps us check for rib fractures, hemothorax, pneumothorax, and injuries to major vessels or airways like the aorta and trachea. If a patient swallowed a foreign object, And we also use imaging to identify infections like pneumonia or complications after surgery, for example, fluid collections or air leaks. So in general, if there's something going on in the chest, imaging helps us figure it out quickly and safely. Now let's talk about what we mean by a critical result. This is any finding that could be life-threatening or cause severe complications if not addressed right away. These kinds of results need urgent care. They need to be communicated quickly whether the result is really bad or even unexpectedly normal. As rad techs, it's important that you can also recognize when an image shows something that might fall into this category. In our institution, we place a strong emphasis on helping our rad tech colleagues recognize critical imaging findings. One critical finding to watch out for is pneumothorax, a sudden lung collapse that can occur even without trauma or injury. It usually happens when small, fragile air sacs near the lung surface, called blebs, burst. When that happens, air escapes into the chest cavity and causes the lung to partially or completely collapse. In the CT image on your left, notice the dark space. That's air that has leaked outside the lung. You can also see how the lung has shrunk away from the chest wall, confirming the collapse. This chest X-ray shows a case of pneumothorax in a patient imaged in the upright position. There are three key features to look out for. First, note the dark area with no lung markings. This represents air that has escaped into the pleural space. It's highlighted here with a white arrow. Next, look for the thin white line. That's the pleural line, which marks the edge of the collapsed lung. It's shown here by the yellow arrow. And finally, notice the flattening of the diaphragm, which is a subtle but important clue. This is indicated by the orange arrow. This image shows a lateral decubitus chest X-ray, which is especially useful when we are suspecting a pneumothorax but the patient can be positioned upright. In this view, the patient lies on their side with the suspected pneumothorax side facing up. And why do we do this maneuver? Because if there's air in the pleural space, the lung will fall away from the chest wall due to gravity. This makes the air pocket more visible as a dark space without lung markings. It's a great alternative for critically ill or bedridden patients who can't sit or stand for a standard chest X-ray. Another alternative is an expiratory radiograph, which is a regular chest X-ray taken at end expiration. During expiration, the lung volume is reduced, which makes the pneumothorax more prominent and easier to identify. When evaluating a chest X-ray for pneumothorax, it's important to watch out for pitfalls, which are things that can look like a pneumothorax but actually are not. Some common mimics include a skin fold, air between the chest wall and the arm, the edge of the scapula, bullous emphysema, and even blankets, sheets, or patient positioning. This image shows one of the most common pitfalls when evaluating for pneumothorax, a skin fold. Take a look at the yellow arrow. It's pointing to a line that might initially look like the pleural line of a collapsed lung. But the clue here is, lung markings are still visible beyond the line, which shouldn't happen in a true pneumothorax. It's critical to spot this correctly because mistaking a skin fold for pneumothorax could lead to unnecessary interventions. This slide focuses on pneumomediastinum, which refers to the presence of air in the mediastinum. Air can enter the mediastinum through several causes, including chest trauma, post-surgical complications, esophageal rupture, and iatrogenic causes, meaning air introduced accidentally during procedures like bronchoscopy or tracheostomy. The illustration here shows how air can leak and track through the mediastinal tissues, outlining structures and spreading through soft tissue planes. This slide shows one of the classic signs of pneumomediastinum on a chest X-ray, the continuous diaphragm sign. Normally, the central part of the diaphragm is hidden behind the heart shadow on a frontal view. But when there's air in the mediastinum, it outlines the heart, making the entire diaphragm visible across the chest. The arrows on both images show the diaphragm, which is clearly outlined beneath the heart, which is a clue that air is tracking around the mediastinum. These are CT images of pneumomediastinum. On the left, we are looking at a CT at the neck level. You can see that there are dark streaks of air tracking along the soft tissues. This is abnormal and indicates air has escaped into spaces where it shouldn't be. And on the right, the chest CT clearly shows air outlining the trachea and surrounding the heart structures. These black pockets in the center of the chest are classic signs of free mediastinal air. A commonly involved pitfall in the diagnosis of pneumomediastinum is the MAC band effect. In this chest X-ray, you'll notice dark bands along the edges of the heart, particularly at the lower borders, which is outlined by the blue arrows. At first glance, these bands might look like pneumomediastinum, but they are not real. The Mach band effect happens when there's a sharp contrast between bright and dark areas, and in this case, between the bright heart silhouette and the darker lungs. Our eyes interpret this contrast as an exaggerated shadow. This slide shows a case of a malpositioned endotracheal tube, which is a critical finding, especially in emergency and ICU settings. In the image on the left, the blue arrow points to the ET tube tip, which is already past the carina and into the right main bronchus. When this happens, only the right lung gets ventilated and the left lung is underventilated, increasing the risk of atelectasis and other complications. Now, compare that to the image on the right, which shows proper placement. Ideally, the ET tube tip should be about 3 to 5 centimeters above the carina, typically landing between the T2 and T4 vertebral levels on a well-positioned film. This slide shows 2 examples of malpositioned nasogastric tubes and 1 example of correct placement on the right. Let's start with the image on the left. The yellow arrow points to a tube that has coiled upwards instead of going down into the stomach. This can happen if the tube loops in the upper esophagus, and in this case, it clearly needs to be repositioned. In the middle image, the tube ends near the gastroesophageal junction, which is higher than ideal. It hasn't reached the stomach yet, so this is considered inadequate. Now on the right, we see an ideal nasogastric tube placement. It follows a smooth path down and coils nicely in the stomach. Another critical finding to be aware of is foreign body aspiration. In the left image, the blue arrow points to a small, round radio-opaque object lodged in the right main bronchus. This location is common because the right bronchus is wider and more vertical, making it the path of least resistance for aspirated materials. In the middle and right images, the round radio-opaque object is tucked within the esophagus. While these conditions are most often seen in children, it can also definitely occur in adults, especially those with impaired swallowing or neurologic conditions. This slide shows 2 CT images from a case of chest trauma, highlighting the value of CT in evaluating complex injuries. On the left, you can see multiple rib fractures indicated by the white arrows. On the right, we see a diaphragmatic injury, another serious finding that can be easily missed without advanced imaging. CT is incredibly useful in trauma cases because it not only detects bony injuries, but also reveals damage to soft tissues, organs, and major blood vessels, many of which might be missed on plain chest X-ray. This is why CT is often the first-line imaging tool in evaluating significant chest trauma, especially after motor vehicle accidents or high-impact injuries. These are CT images which highlights advanced findings in chest trauma, focusing on injuries involving the internal organs and airways. On the left CT image, we observe fluid accumulation around the heart and lungs, which is concerning for hemopericardium and hemothorax. These are serious complications that often indicate significant internal bleeding and require urgent attention. On the right, we see a volume-rendered CT image of the trachea and main bronchi. The black arrow points to a tracheal transection, a rare but life-threatening injury typically caused by high-impact blunt chest trauma. This slide is just a summary of the common chest injuries after trauma, divided into pulmonary and pleural types. From the left, contusions are lung bruises, more visible after 2 days post-injury. Lacerations are lung tears that may form cavities or air fluid levels. Hematomas are blood collections that may mimic masses and need follow-up. Hemothorax is blood in the pleural space, seen as dense fluid on CT. Pneumothorax is air in the pleural space, best seen on upright chest X-rays. Chest X-ray is the first step, but CT gives a more detailed view when possible. Now that we've covered chest trauma, let's move on to imaging key vascular structures, the pulmonary arteries, aorta, and coronary arteries. These are vital to assess in emergencies where conditions like pulmonary embolism, aortic dissection, and heart attacks can be life-threatening. Accurate diagnosis depends not only on interpretation but also on image quality, and that's where rad techs are essential. Proper contrast timing, patient positioning, and clear breath-holding instructions are all crucial. If even one of these steps is missed, it can significantly compromise image quality and make interpretation very challenging for any radiologist. These are CT images demonstrating an acute pulmonary embolism. Here, you can see filling defects, the dark areas within the contrast-filled arteries, indicating the presence of a clot. This is a life-threatening condition that can impair oxygen exchange in the lungs. Detecting pulmonary embolism depends on proper contrast timing, high-quality images, and clear visualization of the vessels, all of which highlight the vital role of the technologists during the scan. This slide highlights a common pitfall in CT of the pulmonary arteries, which is the flow artifact. At first glance, the left pulmonary artery appears to have a clot due to areas that resemble filling defects, but is actually an artifact caused by uneven or delayed mixing of contrast, often due to suboptimal timing or inconsistent flow. The venous face image on the right confirms the arteries are patent with no real clot present. This emphasizes the importance of precise contrast timing and injection technique. This slide focuses on thoracic aortic aneurysms, which are dilatations of the aorta that can lead to life-threatening complications if undetected. On the left, a chest X-ray reveals a widened upper mediastinum, a clue which suggests an aneurysm. We classify the aorta as dilated when it measures between 4 to 4.5 centimeters and aneurysmal when it exceeds 4.5 centimeters in diameter. This slide shows contrast-enhanced CT images illustrating an acute aortic dissection. An aortic dissection occurs when a tear in the inner layer of the aorta allows blood to enter the vessel wall, separating its layers and creating a false lumen alongside the true lumen. This separation can disrupt blood flow to the vital organs or lead to aortic rupture. On the CT images, observe the intimal flap dividing the aorta into two channels. The true lumen is typically smaller and may be compressed, while the false lumen often appears larger and may show delayed contrast enhancement. Coronary CT in the emergency setting is still not widely used in the Philippines, but it's becoming increasingly valuable, especially for evaluating patients with suspected acute coronary syndrome who are at low to intermediate risk, meaning those with no ECG changes and negative troponin. This slide shows a coronary CT scan revealing an occlusion in the proximal left anterior descending artery with matching anterior perfusion defect, suggestive of ischemia or even infarction. CT coronary angiography is powerful because of its high negative predictive value, meaning if the scan appears normal, it's highly unlikely that the patient has significant coronary artery disease. This slide shows a common issue we sometimes face in cardiovascular CT, which is the cardiac motion artifact. Since the heart is constantly in motion, parts of it, especially near the aortic root, can appear blurry or distorted in the images. In the left image, for example, the white arrow points to a blurry area that could easily be mistaken for something serious like a dissection. You'll also notice in the middle and right images, the vessels look wavy or have double contours. Again, that's not a real pathology, it's just the heart moving during the scan. That's why scan timing, ECG gating, and good patient cooperation are so important. I won't get into the technical side of ECG gating, but if your institution has it, it's much better to use it as it helps reduce artifacts like this and prevents us from mistaking motion from a true abnormality. This slide shows how cardiac motion can impact CT image quality, especially when we are looking at the coronary arteries. On the left, we see a coronary CT image where the artery looks blurry. The arrow points to what might be mistaken for a lesion or blockage, but it's actually just a motion artifact. On the right, we have a set of images showing the heart at different points in the cardiac cycle, from 0% to 80%. And notice how the clarity of the coronary arteries changes throughout. At around 40%, the image is the sharpest. This is what we call the optimal phase. It's the phase we aim to capture in an ECG-gated cardiac CT. Next, let's talk about breathing artifacts, another common pitfall in CT imaging. On the left, the green arrows show misalignment in the aorta. This happens when the patient breathes or moves during the scan, causing the images to shift or blur. On the right, we see coronary CT images. Some of them look broken, wavy, or doubled, especially where the white arrows are pointing. These distortions can mimic narrowing or stenosis and might lead to a false diagnosis if we are not careful. Breathing artifacts are a big challenge in cardiac CT where we need very precise images to evaluate small coronary vessels. That's why patient cooperation is so important. A clear breath hold and good communication can make a huge difference in image quality. This slide highlights a subtle but important pitfall in contrast-enhanced CT, which is incorrect tracker placement. When we perform contrast studies, especially for vascular imaging like the aorta or pulmonary arteries, we use a tracker to monitor the contrast bolus and time the scan properly. On the left are plain images where we cannot appreciate the presence of a dissection. But on the right, after contrast infusion, we do see a dissection. And here's the problem. The ROI was placed mostly in the false lumen of the aorta. Because of that, the scanner detected the contrast late, which led to delayed timing and suboptimal image quality. This slide introduces a specialized but less commonly used scan called CT triple rule-out. It was designed to evaluate 3 life-threatening causes of chest pain, which we were able to discuss earlier by using only a single exam. It's especially helpful in emergency settings when a patient presents with non-specific chest pain and we need to quickly rule out all 3 conditions without performing multiple separate tests. However, this scan is technically demanding. It requires precise contrast timing, excellent image quality, and sometimes medications like beta blockers to slow the heart rate for better visualization. And protocols can vary depending on the scanner, the patient, and the hospital's guidelines, which is why it's so important for technologists to be familiar with their local protocols and to work closely with the radiologists to ensure a successful exam. Again, the main goal of a CT triple rollout is to evaluate for 3 critical conditions in one go. To do that effectively, we need good contrast opacification in both the right and left heart chambers because the right heart needs to be well opacified to assess the pulmonary arteries for embolism, and the left heart also needs to be opacified to evaluate the aorta and coronary arteries. But it's tricky because we need just the right balance. If the contrast is too dense, it can cause streak artifacts that can obscure the image. If it's too weak, the vessels might not enhance enough to be diagnostic. In the images shown, you'll notice that there is good opacification of both chambers without significant streak artifacts, which is exactly what we aim for in a good triple rule-out scan. This balance depends heavily on timing, contrast injection technique, and of course the rad tech's skill in setting up the scan. Since we are trying to evaluate the aorta, coronary arteries, and pulmonary arteries in a single scan, contrast timing becomes absolutely critical. We can achieve this by adjusting the amount, flow rate, and phasing of the contrast and saline injection. The goal is to get both the right and left sides of the heart properly opacified, not too bright to cause streak artifacts, and not too faint to make the study non-diagnostic. Personally, I find this as one of the simpler protocols once you understand the timing. Now, in this protocol, we start by injecting about 70 ml of pure contrast. That enhances the right heart first. Right after, we follow up with a second phase, a mix of contrast and saline. By the time the pure contrast is moving into the left heart, the contrast saline mix is now entering the right heart, which helps visualize the pulmonary arteries without flooding them with too much contrast. This carefully timed sequence allows us to get quality images of all 3 target areas in one scan. Alternatively, by adjusting the contrast and saline amount and infusion rates, you can still achieve the same scan. The choice of protocol will mainly depend on the scanner, the patient, and the institutional preference, but either way, a well-executed contrast injection is key here in getting a high-quality diagnostic study. Getting high-quality images of the major vessels and coronary arteries requires a bit more preparation compared to the other parts of the body. That's because the chest is constantly in motion, not just from the movement of the heart, but also from the movement of the diaphragm and the lungs. So in addition to the basics, like avoiding patient movement or rotation, proper centering, correct exposure settings, and using markers or labels, cardiac and vascular CT often needs extra steps even in an emergency setting. This can include quick preparations like giving pre-medications to slow the heart rate, using ECG gating to time the scan with the cardiac cycle, and most importantly, providing clear breath-holding instructions to the patient. These steps, though simple, can make a big difference in image quality. And once again, they highlight how critical the role of the rad tech is in achieving a successful scan. Let's wrap up with a few important points from today's session. First, high-quality imaging doesn't just happen. It's the result of teamwork, from skilled rad techs and solid protocols to reliable equipment. Second, the accuracy of a radiology report depends entirely on the quality of images. Even the best radiologists cannot make the right call if the scan is suboptimal. That's why attention to image quality is so important. And lastly, in emergency cases, time is critical. Early detection of life-threatening findings can make all the difference. The sooner we identify the problem, the sooner we can intervene, and that can ultimately save lives. And these are my references. Thank you everyone for your attention.
Thank you, Dr. Kais Mumani, for a high-impact and high-yield lecture. To give an inspirational message to our Radiologic technologists and other attendees, please welcome Dr. Orestes P. Monson, Member, Board of Radiologic Technology, Professional Regulation Commission.
Good day to everyone. We welcome you to this symposium to participate in the St. Luke's Medical Center Emergency Radiology Symposium. Let me just greet the organizers and our well-known speakers to this postgraduate course. Good morning to everyone. May I also greet my fellow members of the Board of Radiologic Technology at the Professional Regulations Commission. Beginning with our chairman, Honorable Reynaldo Tisado, and members, Honorable Bayani San Juan, Honorable Maria Josette Canales, and Honorable Roland Punanan. We work together as a team to initiate and support the progress of radiologic technology and X-ray technology in the country. It is with great pride and happiness that we welcome our radiologic and X-ray technologists to this wonderful online and face-to-face learning event. May I also congratulate the St. Luke's Medical Center, the Department of Radiology, for their program for continuing professional development for radiologic technologists. We do not have so many program providers in the board of RadTech, CPD, and we welcome other learning institutions, the academe, and hospitals to give their share to educate our RadTech. Radiologic technology is part of the healthcare cluster of the PRC out of the total number of 46 boards. In the hospital setting, the RadTech, together with the radiologist, the medical physicist, the medical technologist, and the nurses, belong to a working team in the department. This year marks the 130th anniversary of the discovery of X-rays by William Conrad Röntgen on November 8, 1895. The RadTech Professional Societies celebrate in November to honor World Radiography Day. The PSGRT, or the Philippine Society of Government Radiologic Society, holds its annual convention coinciding with the World Radiography Day every November. My message to the RadTech today is to participate in this conference and to practice the 5 love languages of radiologic technology whenever you meet patients in the department for a procedure. The 5 love languages is a takeoff from the book by Gary Chapman. So remember the word CARES, that is cares, that would express the basic professional relationship between the RadTech and their patient. Letter C is caring and encouraging words. These are spoken word language. It takes care of the informed consent and how you communicate to the patient, how the procedure is done. Letter A from cares is act of service. This is an action or a sign language. The radiologic technologist does the procedure for the best interest of the patient. The X-ray films on print or on monitor should be an excellent recording of the X-ray procedure. Letter R is rewards. This is an action or sign language. You will be rewarded as a good radiologic technologist anywhere you go if you practice the ethical part of the profession. Letter E is encounter your patient. This is a spoken word and an action language. Patients should not be referred to as a number or as a procedure. A patient is another person with feelings, and at the moment would have fear, anxiety, and apprehension. because of the procedure may uncover a disease that may impact their lives. Talking and knowing your patient is the key to the basic relationship of a rad tech to his patient, which is mutual trust and confidence. And you have to earn it as a good radiologic technologist. Lastly, letter S is seek something physical. This is a sign language. When the radiologic technologist does the procedure, you must ask permission to touch and position the patient. On behalf of the Board of Radiologic Technology, may we send our heartfelt congratulations to the organizers, to the speakers, and to the radiologic technologists in attendance. Emergency radiology for radiologic technologists is a learning tree for all of us. Coming out of this conference, the radiologic technologists bring with them learning outcomes that fulfill the RadTech's continuing professional development. Have a pleasant day, everyone, and God bless to all. Thank you.
Thank you, Dr. Resty Munson, for that inspiring message. Our next speaker is Dr. Al Patrick Alahas, an abdominal radiologist from Southern Philippines Medical Center in Davao City. His topic is on acute abdominal pain and trauma in adults.
Hi, I'm Dr. Al Patrick Alahas, and I will be discussing about the common abdominal emergency cases. This lecture aims to discuss common abdominal emergency conditions and related diseases, discuss findings of abdominal emergency cases, and discuss the mimics of diseases and techniques of imaging in the evaluation of abdominal emergencies. Most of abdominal emergencies present with abdominal pain, and in the context of emergencies, it often signals potentially life-threatening conditions that demand rapid assessment, where imaging plays a vital role in identifying true emergency cases. Different diseases often have different locations of pain. So, for example, gallstones and cholecystitis are typically in the right upper quadrant, duodenal ulcers, stomach ulcers in the epigastric region, renal stones, ureteral colic in the flanks, pancreatitis in the umbilical region, appendicitis in the right lower quadrant, and diverticulitis in the left lower quadrant. There is oftentimes confusion among students and trainees of the following terms, which all relate to biliary stones. First is cholecystolithiasis, meaning the stone is within the gallbladder. Next is choledocolithiasis, meaning the stone is within the common bile duct or your CBD. And lastly, cholelithiasis is just the general term for gallstones, regardless of location. When scanning patients presenting with right upper quadrant pain, wherein the primary consideration is acute cholecystitis, a handy sign that we can use is called the West sign, meaning wall echo shadow sign. So the wall pertains to the gallbladder wall, which is the thin echogenic line in the near field. The echo pertains to the stone itself. This can be caused by the large stone that almost completely fills the gallbladder, or multiple small stones that are aggregately completely filling also the gallbladder. And the shadow is produced by the stones. So we see here another example of the West sign, wherein you have a thin echogenic wall, the stone, and the shadow produced by the stone. And this is also another view of this image. Here is a closer view of the West sign. So we see here the gallbladder wall, which appears as a thin echogenic structure, the large stone that almost completely fills the gallbladder, and the shadow produced by the stone. The anechoic portion here is just the bile within the gallbladder. And in patients presenting with right upper quadrant pain, wherein you have a hard time looking for the gallbladder, sometimes this West sign mimics the appearance of a gas-filled intestine, as we see here on your right. So you can differentiate the two because the shadow produced by the stones are typically more solid and darker as compared to the heterogeneous or dirty shadowing produced by gas. An important mimic of the wall echo shadow sign is what we call emphysematous cholecystitis, wherein there is gas within the walls of the gallbladder caused by severe infection. Typically, the patients are elderly and diabetics because of compromised immunity. And in the two cases that I have encountered during training and in practice, both patients were elderly and diabetics. So, the appearance of this emphysematous cholecystitis is similar to the West sign. However, you don't see the um, wall or two echogenic structures that represent the wall and the stone because the wall itself is filled with gas. And second, you can differentiate the two because, again, the shadowing caused by gas, regardless of location, is typically less or more heterogeneous and less dark compared to the ones caused by stones, which are darker and more solid in appearance. And also, clinically, sometimes the patients are septic or with elevated WBC. So, it also helps clinch the diagnosis of emphysematous cholecystitis. Here's a side-by-side comparison between a large cholecystitis producing a West sign and emphysematous cholecystitis. So take note that the shadow in West sign or that caused by the stone is more solid as compared to the dirty shadowing produced by gas and emphysematous cholecystitis. There are times that the gallbladder is very difficult to visualize, even to those experienced with scanning. And one important condition to be aware of is the hepatization of the gallbladder, wherein the gallbladder appears similar in echogenicity or density to the liver parenchyma, making it very difficult to visualize. So, for example, here, this is the normal gallbladder because it is filled with bile, which appears anechoic, then it is or it can be distinctly separated or identified from the liver. However, in cases of hepatization because of gallbladder sludge, then the gallbladder appears similar in echogenicity compared to the liver parenchyma. Hence, it's very difficult to visualize if you're not careful. This is an image showing the hepatization of the gallbladder. And as you can see here, the gallbladder appears isoechoic to that of the liver parenchyma. And if you're not careful, you might be able to miss the gallbladder and not identify the pathology that's causing the right upper quadrant pain. So it's very important to actively look for this finding, especially if you have a hard time looking for the gallbladder. When you don't see the gallbladder during scanning, you think of these possible causes. First is that the patient had prior surgery already, and next are the factors that we discussed earlier, such as the hepatization caused by bile sludge, the West sign caused by stones, or gas caused by emphysematous cholecystitis or severe infection. Next is it could also be caused by the rotation of the gallbladder fossa secondary to cirrhosis or decrease in size of the hepatic lobes. So there is displacement of the gallbladder depending on which side the atrophy occurs. And lastly, but very rarely, is that maybe the gallbladder is really absent or congenitally absent. Next, we proceed now to another small organ called the appendix. Modern evidence point that the appendix contributes to immunity and helps maintain overall gut health. Sometimes they implicate the appendix as contributing to the mucin within the colon. However, despite these potential roles, the appendix is still not essential for survival. And the image here shows the variable location of the appendix. So it could be anterior to the ileum, posterior to the ilium, posterior to the cecum, and all the other variations that we see here. So, meaning it's really hard to predict the location of the appendix, and hence during emergencies, sometimes it is very difficult to visualize, especially the retrocecal and the post-ilial locations, because they are obscured or might be obscured by a gas-filled intestinal segment anterior to the appendix. An important landmark in locating the appendix during scanning is the McBurney's point, and this is located 1/3 from the anterior superior iliac spine to the umbilicus. The anterior superior iliac spine is the palpable, the bony prominence in this region, so it's easily identified. The McBurney's point is the assumed location of the base of the appendix, and you have a high chance of seeing the appendix when you scan this area. So here are example images of appendicitis. So when locating the appendix, you scan the right lower quadrant and look for a blind ending tubular structure that is not compressible. And when you measure the diameter, it should measure more than 6 millimeters or 0.6 centimeters cm. And I should emphasize that when measuring the diameter of the appendix, you must measure from the outer wall to the outer wall. We have here an example of ruptured appendicitis. And as you can see here, there is already fluid collection surrounding the appendix or beside the appendix. And you see the defect or perforation in the wall of the appendix. So here is another example wherein you see the fluid collection. Next, we proceed now to the urinary system. And similar to the biliary system, some terms confuse trainees or beginners or student sonographers. So the term urolithiasis is the universal term for urinary tract stones regardless of location. Nephrolithiasis refers to stones within the kidneys, ureterolithiasis within the ureters, cystolithiasis within the urinary bladder, and erythrolithiasis within the urethra. We are very familiar with posterior acoustic shadowing, but a more sensitive way of depicting stones is elicited by Doppler scan, called the twinkling artifact. This is also produced posterior to the stone. So our example here, we see that the stone is very difficult to visualize, and there is somehow posterior acoustic shadowing here. But on twinkling artifact or using the Doppler scan, it's easy to identify that there is a stone here producing the artifact. So what we see here are ureteral jets coming from the right ureter and the left ureter. So these are normal findings. If you don't see ureteral jets on one side or in the same side as with the obstruction, then probably there's a lesion or stone along the urinary tract preventing the flow of urine from entering the urinary bladder. So this is an indirect clue that there is complete obstruction if you don't see anymore these ureteral jets. When we have obstruction along the urinary tract by stones or masses, there is resultant dilatation of the collecting system. So shown here are examples of dilated renal collecting system, the calyces and the renal pelvis on ultrasound, and also here on CT. So it could be termed as pelvic ectasis or hydronephrosis. But what exactly is the difference between the two? Both terms refer to dilatation of the renal collecting system, particularly in the kidneys. So pelvic atelectasis is often benign or physiologic, while hydronephrosis is usually pathologic and there's an identified obstructing lesion such as stones or masses. Pelvic atelectasis is often seen in pediatric or fetal ultrasound. When you scan newborn patients, they usually have mildly dilated renal pelvis secondary to immature ureteral contractions or reflux from the urinary bladder. While hydronephrosis, because it is more pathologic, then they are more commonly seen in adults. Pelvic atelectasis, there's no treatment required, and hydronephrosis needs treatment to relieve the obstruction. In diabetics, we also see severe infection of the kidneys called emphysematous pyelonephritis, and this is similar to what we see in the gallbladder. So the findings are similar. We have air causing dirty shadowing posteriorly, and this mimics stone. However, on stones, there is a more solid and darker shadowing emanating from the stone. Here we have two patients with proven ruptured viscous and pneumoperitoneum seen on CT scan. In the patient on the left, the pneumoperitoneum is well visualized in this upright chest radiograph. As compared to the patient on the right, the upright abdominal radiograph hardly depicts the pneumoperitoneum, but it could be present here. And this is explained by the fact that the X-ray beam is more tangent than the diaphragm on an upright chest radiograph. So upright chest radiograph is more sensitive than upright abdominal radiograph in the detection of small or minimal pneumoperitoneum. In the assessment of pneumoperitoneum on CT scan, we use lung windows in order to detect very minimal or small amounts of air, as we see here. So air is usually settled or usually settles in the non-dependent portion, as in contrast to fluid which settles in the dependent portions. So in order to visualize the small pockets of air, it's very important to use lung windows. In trauma patients, we use the focused assessment with sonography for trauma or your fast ultrasound, and the main goal of which is to detect free fluid in the chest and abdomen. And this fluid is assumed to be blood secondary to trauma. And sometimes it can, or it will be able to detect solid organ injury. So the areas to be assessed on fast ultrasound is the right upper quadrant, the hepatorenal space, the left upper quadrant or the splenorenal space, the pelvis, the cardiac for presence of pericardial effusions, and we also have your extended fast, wherein we assess the pleura for the presence of pleural fluid. So we have here positive fast images. So the example here is in the right upper quadrant or the hepatorenal space, we see anechoic fluid collection, which is assumed to be blood. And here also we have anechoic fluid collection, posterior and superior to the urinary bladder. And again, this is assumed to be hemoperitoneum. In patients who are positive for FAST, we usually subject these patients to CT scan in order to rule out other injuries, especially of the solid abdominal organs. And I want to emphasize here the importance of contrast because as we see here on plain study, there is some heterogeneity in the central portion of the liver, but we don't know if this is a hematoma, a laceration, or other lesion of the liver. However, on post-contrast scan, it is apparent that the lesion in the central portion of the liver is actually a large hematoma with some laceration here. And we also see an active contrast extravasation indicating that the patient is still actively bleeding and it's very unstable. So again, contrast is necessary in the evaluation of post-trauma patients. In the acquisition of CT scan of post-trauma patients, many experts suggest that we use multiphasic scan with emphasis in the acquisition of venous face images. So we have an example here. This is a late arterial image, and we see that the spleen has a very heterogeneous enhancement. And this is normal for the spleen to enhance this way. So the problem here is that we cannot tell if there is laceration here in the parenchyma because of this pattern. And we need venous face images to be able to see that there is actually no laceration in the splenic parenchyma because it enhances homogeneously in this space. Another importance of doing multiphasic scan in post-trauma patients is that on the lead phase, we see that the active hemorrhage becomes larger as compared to the arterial phase images. So here is the plane. You don't see contrast extravasation because there is no contrast in the first place. On arterial, we see a small contrast extravasation, which becomes progressively larger in the venous phase and on delayed phase. So this is also the importance of doing not just arterial phase images in post-trauma patients. As I end this lecture, I want to emphasize some take-home points. Different abdominal pathologies present with different characteristics of the abdominal pain. And there are specific terminologies for stones along the biliary and urinary tracts. The West sign is a handy tool in identifying the stone-filled gallbladder. Air from emphysematous diseases can mimic stones. Pneumoperitoneum is best screened by an upright chest radiograph, and CT is the most sensitive modality to detect pneumoperitoneum. And lastly, multiphasic contrast-enhanced CT scan is imperative in the assessment of active hemorrhage or solid organ injuries. Thank you very much for your kind attention and daghang salamat.
Thank you, Dr. Alahas, for a very well put together and knowledge-filled lecture. Our next speaker is Dr. Andre Hoxon, a radiologist with subspecialty in musculoskeletal imaging. He practices at West Metro Medical Center in Zamboanga City. He will talk about musculoskeletal emergencies.
Good day, everyone. I'm Andre Hoxon. I'm a consultant in West Metro Medical Center of Zamboanga City, specializing in musculoskeletal imaging. And I'm here to discuss my topic for today, which is front table to diagnosis, imaging pearls in musculoskeletal emergency. I don't have any disclosures at this time. For my objectives for today, we should recognize the indications for various imaging modalities in the assessment of musculoskeletal emergencies, emphasizing when to use X-ray, CT, MRI, and ultrasound based on clinical presentation. We are to demonstrate proper imaging techniques for accurate evaluation of acute musculoskeletal injuries, including trauma protocols in emergency settings, and also to understand critical imaging findings to ensure timely communication with the radiology and emergency teams, highlighting red flag findings such as open fractures, dislocations, compartment syndrome, and the technologist's role in urgent cases. So For acute imaging of the trauma patient, it often focuses upon the torso, spine, and head, as these are the areas where acute life-threatening or changing injuries occur. Unfortunately, the extremities are often overlooked or at best are only evaluated by plain radiographs. MSK trauma is commonly encountered in emergency departments. The degree of MSK trauma ranges from trivial injuries to significant life-threatening injuries. Imaging plays an integral role in diagnosis and management of these injuries. The most commonly used modality in the diagnosis of MSK injuries continues to be plain radiographs. And ultrasound is used for the evaluation of soft tissues, which can be multiplanar and has dynamic capabilities. So for more complex injuries, CT is still the most commonly and available, widely used cross-sectional imaging tool. Although CT has many advantages, the soft tissue data offered by CT scanning is limited in the evaluation of MSK injuries. MRI produces excellent soft tissue contrast and fine anatomical detail. The availability of MRI imaging in emergency centers has gradually increased over the years, and in major trauma centers, the availability of MRI imaging is 24 hours a day, 7 days a week, so it is now a standard. Our corresponding increase in subspecialist availability in orthopedics and trauma and increased reliance on complex MSK trauma evaluation has further contributed to the increased use of MRI imaging in the emergency room setting. MRI provides definitive diagnosis of soft tissue and bone injury both in low velocity and high velocity trauma. So ordering the appropriate imaging can decrease the time to intervention, identify associated injuries, and aid in surgical planning. Emergency imaging and radiological workup in trauma care have been reported as the perfect storm for radiological errors, given the fact that radiologists and radiographers have to cope with factors that impair proper scanning and image interpretation, such as uncooperative patients, inadequate medical histories, time-critical decisions, and concurrent tasks, especially during night shifts or weekend shifts. The majority of diagnoses missed in the emergency setting are fractures. Thus, the musculoskeletal region is the main area for dismissed pathologies in the emergency radiology setting. For instance, in a study made in a Taiwanese emergency room department, the missed fracture rate in radiological reports was 3.7%. The authors identified the joints as risk areas and reported the prevalence of missed fractures in the following locations: 8% in the foot, 6% in the knee, 6% in the elbow, 5% in the hand, 4% in the wrist, 4% in the hip, and 3% in the ankle. So here is a table in a study done showing factors contributing to missed fractures in and the corresponding measures given. The two predominant factors which make up 70% of the missed fractures were first the subtle but still visible fractures and radiographically imperceptible fractures. And of course, with regards to the proper imaging, we'll have to fall into the 5 and 2% category. So let's impart some pearls of wisdom to reduce the number of missed pathologies of the musculoskeletal system in the emergency radiology setting. So first pearl of wisdom, use additional imaging in case of doubt. When there is high clinical index of suspicion for a fracture, despite the initial negative radiographic findings, additional CT or MRI examinations are recommended, particularly if the results would affect clinical management. So as an example here, we have a 50-year-old male, 3 weeks prior to consult. The patient claims to have sudden pain on the right knee after jogging. Patient denies any history of trauma. So in the lateral and AP views of the right knee, all we can see is a band-like sclerotic focus along the medial tibial condyle. No dislocations, so we recommended cross-sectional imaging. MRI was done with the coronal T1 weighted and T2 fat SAT images showing a T1 linear transverse hypointensity in the medial tibial condyle with associated marrow edema, as we can see in the T2 FATSAT images. We sign this out as transverse stress fracture of the medial tibial condyle with associated marrow and soft tissue edema.
So for the second pearl of wisdom, which is to perform proper imaging, I consider this to be the most important foundation of imaging. Proper techniques must also be used in the respective modalities in correlation with the knowledge and clinical information from the patient, and the precise correlation of physical examination findings such as the site of maximum pain. And with radiologic imaging, it is helpful for the proper reporting of the findings.
So for X-ray, when assessing for possible fracture, providers should order radiographs of the affected body part as well as the joints above and below the injury to rule out additional injury or interarticular involvement. And also make sure that you order more than one view or at least on 2 planes. For ultrasound, we should make sure that we use the right probe, which is a high frequency linear transducer, which provides the resolution needed to detect subtle cortical disruptions. For deeper structures, our curvilinear probe may be used, but this would sacrifice details. Also, patient positioning is important. We position the patient to allow full access to the area of interest, minimizing movement. Immobilize the limb if necessary to avoid missing subtle cortical breaks due to motion artifact. We should also have systematic scanning technique. Longitudinal and transverse planes are mandatory. A fracture may only be visible in one. Dynamic scanning helps. We should just apply gentle pressure or ask for slight movement if tolerable to see separation or movement of the fracture site. Cortical disruption is key. So look for step-offs, irregularities, or discontinuity in the hyperechoic cortical line. We should also look for hematoma, which are indirect but supportive findings. Swelling or fluid collections can also clue you in when the cortical disruption isn't obvious. And also scan beyond the pain point. So fractures aren't always where the patient points. Scan proximal and distal to the site. Missing a fracture because you focus only on the point of tenderness is a common and costly mistake. For CT scan, we should always ask for thin section imaging. We usually ask for thin slices or less than or equal to 1 millimeter to improve the spatial resolution and reduce partial volume effect. This is critical for detecting subtle, non-displaced, or hairline fractures. Multiplanar reconstructions or MPR. These are always performed for axial, sagittal, and coronal reconstructions. Fractures can be missed if only axial views are reviewed. Reformatted views often reveal otherwise occult fractures. We should also use bone window settings. This enhances the cortical bone detail and makes subtle fractures more visible compared to soft tissue windows. 3D volume rendering, although optional, can be helpful in surgical planning, visualizing complex or comminuted fractures. Patient and interdisciplinary communication, not essential for detection but useful for assessment and planning. We should have appropriate protocols based on the region. We should have, meaning that we have tailored protocols depending on the anatomical area. For example, in the joints, you should have dedicated extremity protocols to optimize the fine details. And also never forget to correlate with other imaging. We always correlate with X-rays, which are more readily available and offer an initial assessment. CT scan is often used when X-rays are inconclusive, high clinical suspicion persists, and surgical planning is needed. For MRI, the standard MSK technique should include multiplanar proton density, fat-saturated images, a single plane T1 weighted sequence, and a single plane T2 weighted sequence. Fast spin echo imaging should be used to reduce imaging time while maintaining sufficient image quality and detail. In some cases, we begin by obtaining a large field of few coronal stereo images over the area of interest. Once the area of concern is identified, multiplanar PD axial T2 weighted FATSAT and T1 weighted images can be obtained. In addition, single-shot imaging could also be performed for rapid acquisition of images in a patient who cannot stay still. Arthrograms and contrast are unnecessary in MSK evaluation in the trauma setting. Also, in our institution where I trained, we always add radiographs as a complementary study to the MRI. So, as an example here, this is a 32-year-old female twisted with a history of twisted ankle while playing sports. After further history taking, according to her, the most pain she felt is in the foot. Thus, a foot radiograph was ordered. AP and oblique view of the foot shows a complete minimally displaced fracture of the right fifth metatarsal base with associated minimal regional soft tissue swelling. So this is a pseudo-Jones fracture. So for this pearl, as I mentioned before, it requires knowledge of the patient's clinical information. The precise correlation of physical examination findings such as the site of maximum pain with radiologic imaging is also helpful for proper reporting. The benefit of sufficient clinical information to improve radiologists' performance with respect to the selection of the best imaging protocol and reporting has been advocated by both radiologists and trauma surgeons, thereby substantiating the value of close interactions. So in this example, the radiograph is sufficient for the problem. Third pearl of wisdom: know the indirect signs of a fracture when interpreting projection radiographs. So for an example here, we have a 46-year-old male fall, showing you the AP and lateral view. The anterior distal femoral fat pad appears displaced, as we can see here with the arrow, while the posterior distal humeral fat pad is maintained. And in the AP view, we see a step of deformity at the lateral radial head. We sign this out as an incomplete fractured lateral radial head. Additional cross-sectional imaging may be done if clinically indicated. This shows as an example the fat pad sign resulting from hemarthrosis of the elbow joint as an indication of a fracture. Fourth pearl of wisdom: always acquire radiographs on two planes when trauma sequelae are suspected. So many fractures are visible on only a single view. Therefore, there is a risk of a false negative interpretation of a radiographic examination if not all necessary views are obtained, thus substantiating the role of standardized protocols with two or more planes. I'm sure most of us, if not all of us, have seen this meme before. This truly depicts the importance of proper imaging in acquiring radiographs on two planes when trauma sequelae are suspected. So for an example here, we have a 41-year-old male riding a bicycle when he mistakenly made an emergency brake to avoid a pothole and fell on an outstretched hand. AP and lateral views of the wrist were taken. As we can see here in the AP view, we don't see any discrete fracture or dislocation. However, on the lateral view, we can identify a small osseous density which appears to originate from the triquetral bone, relating to an avulsion fracture. So this is what we call the pooping duck sign. So if you could just imagine a duck and its poop. So as we can see here, this is a perfect example of the importance of additional planes, especially in trauma cases.
So for the fifth pearl, we should know the limitations of the selected imaging modality. So for example here, we have a patient here that's 45-year-old male came in for executive checkup and was complaining of a lump along the dorsal surface of his hand. According to the patient, he denies trauma. So we checked for the fifth metacarpal bone first and looked to the longitudinal view, and no critical findings were identified, as you can see here in the image. Second, the next image shows we went from the longitude to now to the transverse view, and from there we can see the fifth and the fourth metacarpals together with the two oranges. So if you can imagine this here, and there we saw along the lump that he was complaining about, is that we saw a cortical irregularity, as you can see here, along the fourth proximal metacarpal bone. So When we checked it from the longitudinal view, we see that there's a cortical irregularities, as you can see here, compared with the fifth metacarpal, which is smooth and there's no cortical irregularities. We suggested X-ray of the hand for confirmation.
And true enough, the X-ray it shows a minimally displaced, a complete oblique fracture at the fourth metacarpal with signs of healing. We all know that X-rays are far superior to ultrasound in identifying fractures as seen here. For the sixth pearl of wisdom, we look for subtle findings. So as we can see here, these are AP and lateral views of the knee. This is a 34-year-old male with a history of fall resulting to soft tissue contusions to rule out fracture. A cortical irregularity or discontinuity is noted at the lateral aspect of the proximal tibia, with evidence of tissue thickening lateral to this site. We sign this out as a highly suspicious for non-displaced or occult fracture with surrounding soft tissue swelling and suggestive of minimal joint edema and effusion. Follow-up CT scan may be done for further evaluation if clinically warranted. MRI was done with T1 weighted and T2 fat at coronal sequences showing a flake-like fracture in the peripheral aspect of the lateral tibial plateau with surrounding marrow edema, likely a second fracture. So also, after a few weeks, patient came back for a follow-up CT scan was done, showing a longitudinally oriented avulse fracture fragment from the lateral cortex of the lateral tibial plateau. Again, this was signed out as a second fracture.
I will just enumerate again the 6 important pearls of wisdom that we have discussed earlier. So the first one, use additional imaging in case of doubt. Perform proper imaging. Note the indirect signs of fracture when interpreting projection radiographs. Always acquire radiographs on 2 planes when trauma sequelae are suspected. Know the limitations of selected imaging modality. And last of all, look for subtle findings. Thank you for listening.
Thank you, Dr. Hoxon, for your detailed explanation of the various musculoskeletal emergencies. Our next speaker is Dr. Maud Tabige Alvarez, a pediatric radiologist from Chonghua Hospital in Cebu City. Her topic is on imaging of acute abdominal pain in children.
Good morning, everyone. I am Dr. Maud Tabige Alvarez from the Pediatric Radiology section of the Institute of Radiology. Thank you for joining me today. Our focus is emergency radiology, specifically how we evaluate acute abdominal patients and trauma pediatric patients. This topic is highly relevant to your role as radiologic technologists. In emergency settings, your speed, technique, and understanding of the clinical picture can make a huge difference in outcomes. For this session, I will emphasize on the common non-trauma cases. So we will look at radiologic signs, the strengths of each imaging modality, and key conditions you'll encounter from neonatal emergencies to acute appendicitis. Let's begin by reviewing the imaging modalities commonly used in pediatric abdominal emergencies. X-ray is often the first-line tool. It's fast, affordable, and widely available. The 2 most common views are AP supine and cross-tabulateral. The AP supine view serves as our standard abdominal evaluation, while the lateral decubitus and cross-table lateral views are crucial for detecting free gas when bowel perforation is suspected. This is a crowded slide that describes the technical aspects of the different radiographic views, but what I intend for you to take away from this are the indications why we request other views aside from the standard AP supine view. We also use upright and decubitus views to look for air fluid levels, free intraperitoneal air, or foreign bodies. In very ill children, cross-table lateral is preferred when upright positioning is not possible. Abdominal radiography is especially helpful when assessing for bowel obstruction, thereby helping localize the obstructing process to the upper or lower GI tract. In the setting of suspected or known ingested foreign body, radiographs of the chest and/or abdomen can be obtained to further characterize the ingested object if radio-opaque, establish its location in the GI tract, and potential complications to guide management. Fluoroscopy is useful for dynamic studies like upper GI series, air enema for intussusception, and contrast evaluation for obstruction. It's more affordable than CT or MRI and gives us real-time functional data. Ultrasound is often the first-line test in children because it has no ionizing radiation. No sedation is needed and is excellent for hypertrophic pyloric stenosis, appendicitis, and intussusception. CT scan is reserved for trauma, post-operative complications, tumors, or suspected bowel ischemia. While very accurate, we limit its use due to radiation exposure. MRI, especially MR enterography, is used for inflammatory bowel disease, tumor evaluation, or polyp detection. It has no radiation and it has superior soft tissue contrast, but longer scan times and the need for sedation make it less ideal in unstable patients. Before we proceed to the pathologies, let's first look into the normal bowel gas pattern. There is significant heterogeneity in what we describe as normal bowel gas pattern in pediatric patients, and additional variation is present among newborns and neonates. So let's describe the normal gas pattern in this age group. In neonates, gas is usually present in the stomach within 10 to 15 minutes after birth, and gas normally reaches the proximal small bowel within an hour. Gas fills most of the small bowel by 6 hours, and by 12 to 14 hours, gas reaches the large bowel and meconium is typically passed. And at 24 hours, the normal bowel gas pattern in neonates is characterized by gas throughout the small and large bowels, with little fluid with respect to air. The bowel interfaces are thin and sharp, the small and large bowel cannot be distinguished, and the gas distribution is one of multiple, closely opposed, rounded and polyhedral structures. It should be symmetrical in 4 abdominal quadrants, and the bowel loop caliber should not be equal to or greater than the interpedicular distance of L2. So like this. So we should watch for abnormal patterns such as altered caliber, dilated or collapsed loops, discontinuity of gas, asymmetry, paucity of gas, dilated gas-filled loops that are persistently displaced, because these signs help us detect early obstruction, atresia, or perforation. Here are sample AP and supine radiographs in older children. An abnormal bowel gas pattern, like in neonates, are characterized as persistently displaced, dilated, and unusually distributed in the 4 quadrants. Now that we have discussed the normal bowel gas pattern, let us now look into abnormal appearances in the abdominal radiographs, which include free intraperitoneal gas, due to a hollow viscous perforation. In infants and young children, a cross-table lateral view is preferred to an erect view. On image A, free air collecting along the anterior abdominal wall and anterior hepatic surface is clearly depicted on cross-table lateral view. Here. On supine view, it may be identified by the presence of air on both sides of the bowel wall, or air outlining the ligamentum falciparum. It can also be seen as the football sign, as depicted here. Another is ascites, or the accumulation of intraperitoneal fluid. The most common radiographic sign of free peritoneal fluid is separation of the flank fat stripe corresponding to the properitoneal fat line from the gas in the descending colon. Normally, the distance between the two should not exceed 2 millimeters. Another common radiographic sign is central displacement of the bowel loops, here as depicted in this image. Calcifications may be seen in meconium peritonitis, appendicitis with appendicolith, manifestation of biliary and genitourinary tract stone diseases, or with tumors such as neuroblastoma, hepatoblastoma, and teratoma. So we should always correlate with clinical signs like distension, tenderness, or sepsis. Here is a table on the common causes of pediatric abdominal pain requiring urgent medical or surgical management, which I lifted from the Royal Children's Hospital, Melbourne. We shall discuss in more detail some of these. Now let's focus on necrotizing enterocolitis or NEC, which is the most common surgical emergency in neonates, affecting mostly preterm infants. It is considered the most common newborn surgical emergency with greater morbidity and mortality. Approximately 90% of cases of NEC occur in premature infants, and the incidence of NEC is inversely proportional to gestational age, with the majority of cases occurring in infants weighing between 500 and 750 grams. Here is a table of the Bell staging criteria that correlates radiographic findings with the clinical stage. Stage 1, clinically, the child presents with abdominal distension and bloody stools. On radiograph, Stage 1 NEC will show nonspecific diffuse dilatation of bowel loops with caliber greater than the interpedicular distance of L2, as seen here. Stage 2, clinically, there is absence of bowel sounds as well as abdominal tenderness. On imaging, branching lucencies are seen over the liver, as pointed here by the white arrow, which represents portal venous gas. Additionally, there is pneumatosis intestinalis or gas within the bowel wall, as shown here. Similar findings can also be appreciated on ultrasound as branching echogenicities in the liver and along the bowel walls, which represent gas. In stage 3, the child typically will show signs of peritonitis, tenderness, and massive distension. The imaging would show pneumoperitoneum or free intraperitoneal air due to ruptured hollow viscous. Here are images showing pneumoperitoneum on cross-table lateral view, on supine view, as well as lateral decubitus view. here. It is important to recognize these abnormalities and promptly relay them for immediate intervention. Ascites may also be present. As I have said, early detection helps avoid bowel necrosis and death, and as technologists, be prepared to obtain repeat radiographs or cross-table lateral views to confirm the presence of free air and to monitor changing gas patterns. Next is hypertrophic pyloric stenosis, which is one of the most common urgent surgical entity affecting infants during the first 6 months of life. Its cause is unknown. The common final pathway is that of abnormal hypertrophy of the circular muscle of the pylorus that is unable to relax. Here is an illustration of the normal pylorus versus that of a pyloric muscle that is hypertrophied. More than 95% of affected children present in the 3rd to 12th week of life with projectile, non-bilious vomiting. Rarely, symptoms are present in the first week of life or as late as 5 months of age. The clinical diagnosis can be made when an olive-shaped mass is palpated in the epigastrium. This might already be suggested on radiograph, which shows gaseous distension of the stomach. Upper GI series, which was once the mainstay for confirming the diagnosis, can show the string signs and double track sign, which relate to one or more thin strings of contrast coursing through the mucosal interstices of the pyloric channel. Here is a fluoroscopic image from an upper GI study showing an elongated, thin pyloric channel consistent with hypertrophic pyloric stenosis. Here are other images of hypertrophic pyloric stenosis. These are grayscale ultrasound image of the pylorus showing abnormally thickened muscularis propria. Another grayscale ultrasound image shows abnormal pyloric channel elongation. Upper GI series, an oblique image shows thin linear tracts of barium in the pyloric channel, compatible with double track sign because of the redundant mucosa. The pyloric channel never opened during the entire examination. Ultrasonography is a diagnostic study of choice to confirm the diagnosis of hypertrophic pyloric stenosis. Longitudinal and transverse images are acquired with the infant in the right posterior oblique position, which allows fluid in the gastric fundus to flow into the antropyloric area, distending this region. The stomach should not be emptied prior to the examination because this makes identification of the antropyloric area difficult. If the antrum does not contain adequate fluid, a glucose solution or water can be given orally or via a nasogastric tube. Image of the upper left shows longitudinal probe placement with infant in supine position. Below shows a transverse probe placement with infant in right oblique or decubitus position. Typically, a high-frequency 5 to 10 MHz linear or curvilinear transducer is used due to small size and superficial location of structures. Patients should be supine or right lateral decubitus, which to facilitate antrum filling. Start scanning slightly to the right of the epigastrium with graded compression to get rid of excessive bowel gas. Find the gallbladder adjacent to the liver and look medially to locate the pylorus. Alternatively, find the fluid-filled stomach and follow it distally to the pylorus. The aorta and superior mesenteric artery can also be used as additional landmarks if necessary, with the pylorus anterior to them. Here is a long axis view of the pyloric muscle between the white arrows. This is seen at the distal end of the stomach. In between the pyloric muscles is the hyperechoic pyloric channel made up of gastric mucosa. On short axis, or transverse view, the pylorus has a target appearance. The sonographic hallmark of hypertrophic pyloric stenosis is the thickened pyloric muscle, defined as wall thickness equal to or greater than 3 millimeters, and an elongated pyloric channel defined as a length equal to or greater than 17 millimeters. Here is another long axis view of a thickened pyloric muscle and an elongated pyloric channel. Ancillary signs of hypertrophic pyloric stenosis include the antral nipple sign, referring to the presence of prolapsed pyloric channel mucosa into the gastric antrum. There is also a double track sign here, reflecting the presence of hypoechoic stripes of fluid in the crevices of the mucosa. Additionally, the thickened pyloric muscle is hypervascular on Doppler interrogation. Next is intussusception, which is an acquired invagination of the bowel into itself. Approximately 90% to 95% of cases of intussusception in children are ileocolic and idiopathic. Idiopathic intussusception occurs most commonly in infants aged between 3 months and 3 years, with a peak age of 5 to 9 months. The classic clinical presentation of the child with intussusception is the triad of colicky abdominal pain, vomiting, and bloody stools. On X-ray, the visualization of the intussusceptum as an intracolonic mass, outlined by gas, termed the crescent sign, is nearly pathognomonic of intussusception, but it is only seen in approximately 1/3 of cases. Ultrasound is highly sensitive in the detection of intussusception, with sensitivity and specificity at or close to 100%. Ultrasonography for diagnosis of intussusception is performed using graded compression technique. The colon is followed from right to left, and the entire abdomen and pelvis are scanned in both longitudinal and transverse planes. On transverse sonograms, the intussusception appears as a complex mass with alternating concentric, hypoechoic, and hyperechoic rings described as the donut or target sign. The mucosa and submucosa are echogenic, while the muscularis is hypoechoic. The diameter of the intussuscepted bowel exceeds 3 centimeters in maximal diameter. On longitudinal images, the intussusception has a reniform appearance, termed as the pseudo-kidney sign, characterized by alternating hypoechoic and hyperechoic bands. Here. Findings suggesting of decreased chance of non-operative reduction includes trapped fluid in the leading edge of the intussusceptum and absence of flow on Doppler evaluation. Most cases of intussusception are treated with fluoroscopic air enema reduction. This works by increasing the intraluminal pressure, forcing the intussusceptum back to its original position. Contraindications to attempted enema reduction include pneumoperitoneum and peritoneal signs, and the most important potential complication of enema reduction is bowel perforation. The technologist will assist in positioning the patient and may insert the catheter under fluoroscopy and inflate the balloon with gentle traction. So air or contrast pressure is applied up to 120 millimeters mercury while watching the pressure gauge and never going over the limit. Success is seen when contrast flows freely into the small bowel, and they must be ready to decompress immediately if perforation ever happens. Bear in mind the rule of 3. 3-minute sustained pressure at 120 millimeters mercury, maximum of 3 attempts, a total of 9 minutes. Here are fluoroscopic images of hydrostatic complete and incomplete reduction. On your upper right, we see an ileocolic intussusception. Then there's progressive reduction and eventual complete reduction indicated by efflux of contrast into the distal ileum, as pointed by the arrow. Another set of fluoroscopic images below show incomplete reduction indicated by absence of efflux of contrast into the distal ileum. Let's move on to malrotation and volvulus. This is a diagrammatic representation of the normal process of intestinal rotation during development. And failure of this process results in malrotation, which can predispose to midgut volvulus. In midgut volvulus, the duodenum rotates clockwise about the axis of the superior mesenteric artery and is obstructed at its third portion distal to the ampulla of Vater. Vascular compromise may lead to intraluminal bleeding and hematochezia, which are seen in 10% to 15% of patients with volvulus. The upper GI contrast study for malrotation follows a specific 4-step technique. So we position the baby supine and give 5 to 10 ml of water-soluble contrast via nasogastric tube, and turn to the right lateral to observe contrast progression into the duodenum. Return to supine to evaluate the critical duodenojejunal flexure position, and then aspirate remaining contrast, document the findings, and alert the clinician if the findings are abnormal. The key diagnostic criterion is the duodenojejunal flexure position, which is normal when it is at the left of the midline, at or above the level of the duodenal bulb, as seen in illustration A. And malrotation is diagnosed when the duodenojejunal flexure is right of the midline and below the duodenal bulb, as shown here. As illustrated in this fluoroscopic image, malrotation is present when it is right of the midline and below the duodenal bulb. A characteristic corkscrew configuration of the duodenum is seen, as depicted here in image B, if volvulus is also present. So this is a surgical emergency requiring immediate recognition and intervention to prevent bowel necrosis. Although not the imaging of choice for malrotation, ultrasound detection of malrotation relies on evaluating the superior mesenteric artery, superior mesenteric vein relationship using a transverse approach with the patient supine, identifying the SMA origin from the aorta and SMV from the portal confluence. The key diagnostic criterion is vascular positioning. Normally, the SMV is anterior and to the right of SMA. Reversal of this relationship, with the SMV positioned to the left of SMA, is suggestive of mid-gut malrotation, with sensitivity ranging from 53% to 87%. Moreover, the vessel pattern can be indeterminate, with the SMV lying anterior to SMA, which can be seen in patients with normal as well as abnormal rotation. In related literatures, 15 to 20% of the patients with malrotation was identified to have this SMV-SMA position. Lastly, let's talk about acute appendicitis. So this is the most common indication for emergency surgery in older children and adolescents, resulting from appendiceal luminal obstruction, followed by distension, ischemia, and bacterial infection, with classic signs including periumbilical pain migrating to the right lower quadrant, abdominal tenderness, fever, and leukocytosis, although 1/3 of children present with atypical findings. Ultrasound evaluation uses a graded compression technique with a linear array 5 to 7.5 MHz transducer, gradually compressing the right lower quadrant until iliac vessels and psoas muscles are visualized, with patients pointing to the area of maximal tenderness to guide the examination. So we start by placing the linear probe in the transverse position at the level of the umbilicus, apply graded compression, move the probe laterally to identify the ascending colon, down to the end of the cecum, move medially and identify the psoas and iliac vessels, move down the border of the cecum and up the border of the cecum, as shown here in the arrows, and turn the probe into a sagittal position and identify the end of the cecum in the long axis and move medially along the psoas. The key diagnostic criteria distinguish normal appendix from acute appendicitis. So the normal appendix is compressible, it is less than 6 millimeters in diameter, and shows minimal color flow, while acute appendicitis is diagnosed when the appendix is non-compressible, greater than 6 millimeter in diameter, fluid-filled with target appearance, and displays peripheral hyperemia on color Doppler. Critical findings include the presence of appendicolith with acoustic shadowing, pericecal fluid, phlegmon representing inflamed fat and perforation signs such as loss of echogenic submucosa and abscess formation. Although remember that perforated appendices may disintegrate and become invisible in 40 to 60% of cases. CT scan is the next modality of choice when the appendix is not visualized by ultrasound, and similar criteria applies. Likewise, it is important to relay additional findings like the presence of appendicoliths, phlegmon, or abscess formation. To summarize, so it's important that we know the normal gas pattern and the abnormal gas appearances as they help flag pathology. Be familiar with the radiologic signs of necrotizing enterocolitis, pyloric stenosis, intussusception, malrotation, and appendicitis. And mastery of proper positioning and patient preparation enhances diagnostic accuracy. And always think clinically. Your images are not just pictures, they're diagnostic tools. So that would be all. Thank you for your kind attention. Here are my references.
Thank you, Dr. Maud Tabigi Alvarez, for that excellent talk.